COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities.
Few more coming. Hello, everyone, and welcome to this April COIN meeting. Of course, COIN is our network of friends, really, who develop local communities for health and care. Now, for those of you who haven't met me before, my name is Katrine, or Kat, and I'm a Danish PhD student and GP to be. Now, I've been part of COIN for about year and a few months after I was introduced by Paul, and been asked to chair today with a bit of help from Paul and Chris and lovely Lucy. So, the aim of the meeting today is to discuss learning about disseminating messages about community-oriented integrated practice through telling stories and videos. Now, we're particularly thinking about the ideas that we have presented in the 2 COIN papers that's been sent to the consultation process. We have about 11 stories, so we've chosen to split them up into 2 different meetings to make sure we have enough time for everyone and for good discussions. But before we start on those and have a few updates, I'd like to ask newcomers or people who've not been for a while to introduce themselves.
I'm a GP by training, and I did all that training in New York, and ended up in Europe doing a reverse migration. My parents were from Hungary and Russia. Ended up working for USAID in Eastern Europe, and got to meet a lot of people in that area. Didn't like USAID very much. Ended up working for the King's Fund in the UK, and then segued on to working at the WHO European region, and I became head of communications there somehow, and did that work for quite a few years, and retired in 2005 for the 3rd time. I started a company called World Health Communication Associates, which have been working with colleagues on since then, mostly contracting with WHO and other international agencies to do health communication work. And that's what we've been doing, and we've been doing quite a bit of that through the COVID period. And that brings me to why my interest here today, I think, is increasingly understand the challenges of communication and the great growth of infodemic and all that kind of stuff. And as in this last year, we've been working with a German group trying to do some training in emergency response, and we were supposed to try to find where the gaps were in what was being offered internationally. And the gaps that I was seeing a lot was that while there's a lot of continued lip service to community engagement, that has not really happened. And it's an opportunity, I think, a very good opportunity to reestablish a balance which has maybe never or hasn't existed in a proper way. Anyway, we've been playing a lot with the concept now of trying to spread the glow. The glow is our theme that we've been working on as a group. And the glow is not a policy, a product, or a slogan. It's civic energy that pulses whenever people reclaim the ability to protect each other. And I think that COIN has been doing that a lot in terms of neighborhoods and stuff. And I'm really interested to hear how you're doing that and how that has worked. And we're quite keen on trying to spread the glow and put the public back in public health. And what I'd like to share with you tonight is one area that we've been working on in Italy, and that is enjoying the sagras. For too long, I think we've had too narrow a definition of who were public health workers. And pretty much the main group we've been working with the last 4 years is architects and engineers. Then coming into COVID, who got a lot of requests for making facilities safer. And they recruited architects and engineers, many people that were working with Medicine Sans Frontiers and a lot of frontline stuff and trying to make facilities safer. And they've developed an amazing network and are really mainstreamed into emergency response now.
Hi everyone, I'm Connie. I'm a GP in London, and I am here, I suspect, because I piloted the first intervention of community health and wellbeing workers in Westminster based on the Brazilian family health strategy. And I've grown that movement with Matt Harris from Imperial and others in Cornwall with the National Association of Primary Care to now 25 locations that are trying it. And what's really remarkable is it's kind of spreading the glow. It's propagating other than being scaled from the top. I mean, no political support whatsoever, no funding centrally. It's just kind of taking hold in communities, passionate GPs driving it forward together with other communities. And I'm also really interested in sort of the neighborhood approach that is informed by compassionate care, citizenry, sort of activated citizens taking charge of, caring for each other. And I've learned a lot spreading the community health workers, and I'll talk a bit more about that with the video as well. But the sort of people find it, somebody said that, realized that people don't really want community engagement, and that I find that true. People get really freaked out by the polyphony that comes from having to converse with people from the community. It's really messy, and we're not really used to it. And so I can share a lot of learning from the last 3 years of working with the community health workers and patients for the last 3 years.
I'm talking, in fact, I'm not in Rio, I'm in a place called Niterói, it's a nearby city. I know Peter for a long time, since the COVID years, in fact, and we work around cinema, that's my specialty. And recently I had a strong experience concerning the healthcare issue, a personal experience, because my godmother who raised me, now she is a 96-year-old woman. I support her. I do not live with her, but I take her to the doctor. My brother is in charge of her. And the only way that you have to connect with any form of social, non-fierce behavior is when she is surrounded by film, when she's watching a film. And I try to be around her and show her moving images. And since I started this relationship or rearranged my relationship with her, I've been researching films that surround this topic of the end of life, of how to cope with that, how to cope with, I would say one, The Room Next Door. It's a movie by Pedro Almodóvar, the Spanish director. It's a movie about euthanasia. We say euthanasia in Brazil. And, well, I have...
Hi there, I'm in Sheffield in the north of England. My name's Simon Duffy. I'm the kind of wrong kind of doctor. I'm a philosopher rather than a proper doctor, although I think I'm a proper doctor. But anyway, that's a different argument. And but my career has really been very focused on disability and community and inclusion. I'm best known for having invented the personal budget model that's been rather badly implemented, but that's another story, in England and Scotland. And for the last 15 years, I have been very involved in an organisation that I set up called Citizen Network, which is focused on offering hopeful visions of the future and practical solutions, and lots of work that's rooted in communities, particularly here in the north of England. So I think I'm going to be talking a little bit about the work around neighbourhoods of care that we've been doing in South Yorkshire, and the peer support models that we're seeing emerge.
I'm Sam. I'm a GP in the East End of London. I'm also actually, Paul, for your interest, doing a paper on neighbourhood health. What is it? Which will have quite a lot of Bromley by Bow and other similar social prescribing examples there. And I'm Ned of a mental health trust and also on the board of NHS Resolution.
I'm Brian. I haven't been here for a long time.
But you did a really excellent presentation that we still look back to, don't we? That informed the palliative care thing. Go on, Brian. Say something about yourself.
Hi, I'm a retired GP. I've known Paul for 150 years. We've done various things together. I have various interests, but community development is I've been passionate about for decades and have tried to persuade governments to include the concept and the idea in public health and in the NHS and in local authorities, and have singularly so far failed to influence government about this. But I'm now part of the Coalition for Personalised Care, and we are now talking to the neighbourhood team in the Department of Health and Social Care about a set of policies that have been developed with a whole range of organisations over the last year or two. So I'm quite involved in med tech, so I helped to develop the idea and the implementation of patients having access to their GP records. And I'm also working now with helped found a company which automates the management of high blood pressure to save people time and improve care. And I work with a campaign called End Social Care Disgrace, which is fighting for the transformation of social care in various ways.
We've been trying to, like Brian has said, be connecting with the people in the neighbourhood team about community development. We've been trying to meet up with similar people in senior positions to see if we can influence the policy around what COI works, which is similar to yours in many ways, Brian. And we've already met, and I've reported on this, but there are some new people here. We met a deputy permanent secretary of the Department of Health and Social Care, and I've never known a more almost spiritual experience in talking to a civil servant as Paul and I had that day with him. And because normally they are lovely people, but fairly stiff and predictable in many ways. And I worked at the Department of Health for nearly 10 years. So that was a good start because he was very supportive and also gave us some names of people who I already knew. And so we've been working through some of that. So number one, we met the Royal College of GPs and through Camilla, the President Hawthorne, the present chair of the Royal College of GPs. And she was interested enough to have a second meeting with us, which is quite, I think, an event. And now it's at the policy level to see whether they want to be, as an organisation, more fully involved with developing this policy, COI, etc. We also met up with a group I've been closely involved with called the National Association of Primary Care. And they too had the same enthusiasm and were going to take it back to their organisation. And I need to chase them up a bit once we've had some other meetings. So those were the three main starters, all supportive. What does that mean? We also met up with John Oldham, who is the GP now involved in leading on the neighbourhood programme for West Streeting. John and I go back donkey's years when we of the left were traitors and both became non-Tory fund holders and had a devolved budget, which was probably not seen as good on the left, but there we are, that's what we did. And so we've known each other for some time in trying to drive on different views of general practice and putting general practice more central in the health service hierarchies, really, which it's always been an afterthought to some extent. So that's where we've been. Met John, John was very practical about, well, have you got evidence? Have you got this and that? And we didn't get a very great warm response from John, but he was interested enough to meet us and also gave us some other names to get in touch with. So following that, I've arranged meetings with, and these are people I've known in my experience at the centre and things. So we've got an appointment with a thing called the NHS Confederation, which is basically an organisation which looks at from the commissioning point of view of the NHS, and we've got a meeting with the primary care lead for that. And we've also, I'm a fellow and used to be a trustee of a thing called the Queen's Nursing Institute, or now it's known as the Queen's Nursing Institute for Community Nursing. And so we've got an appointment with the current chief exec of that as our next step. The idea behind all this is not just ceaseless activity and rushing around, but what I've always been keen on is, can we get a coalition of people who, even if we aren't allowed to develop the policy ourselves, can influence its development? And that's where we're at. And so it's a mixture of people who are part of the hierarchy and all are quite well known to the hierarchy, and trying to get us together so we can have this concerted coalition. So I'll be interested in, Brian, in what stage you're at in some of your chats too. So that's where we're at. That's our next meetings. And then I need to refresh. I also, Paul won't know this, got in touch with Alan Milburn, who was the First Secretary of State in the Blair government, who obviously I work with as well. And he's also giving advice to West Streeting. West Streeting have a lot of advisors around the neighbourhood policy. And Alan's responded, and quite warmly, and has asked me to send some written material and stuff to him. And so that is a possible avenue. So what we've been trying to do is influence some of the biggish players in this system to see whether this could be absorbed. Because in the Streeting 3, the two areas which are important are the movement to community, which is their neighbourhood policy, but also moving to prevention, because our worry is twofold. One is that if we have neighbourhoods, it might become another structural reform, because the health service, when it goes into reform, finishes up having new structures and very little change in mindset. And the second is that prevention tends to be this rather, you shouldn't smoke, you shouldn't drink, you should do more exercise type of participation approach, rather than actually thinking that health is about empowerment and all the other things that we agree. So we're trying to see if we can use those part of the Streeting 3. The other is about moving to digital, so that's not as apparent, though it's crucial as part of our thinking. And trying to see if we can get some of our thinking into those areas if we're going to have a proper reform in healthcare, which is much more organic and participatory than the usual structural top-down approach.
Everyone recognises that this is terribly important. It goes way back to Alma Ata and the World Declaration of what health is. And how you achieve it seems to be on the too difficult to look at pile. And yet how to achieve it is pretty much what COI discusses all the time. And we've got both experience of making it work and how it can be translated into policy. But when we get to that area in some of these discussions, a little bit of despair enters into the room, virtual room. Oh, we've tried that before and it never worked, kind of thing. Yes, but how do you do this without having any local leadership? How do you just plonk a project into a model into another place and make with the world we want to have happen? And the answer is that, well, you can't. You know, you actually do need to be able to develop enthusiasm and motivation and leadership locally. Oh, but where you can get the money for that comes next. So I found some of this quite dispiriting, actually, because saying yes, this is exactly what you want, but no, we can't possibly use a successful approach to achieving it. How we might be able to almost move forward in this almost by stealth whereby people encounter the need to engage people and participation and share, trusted relationships because of policies that on the face of it look to be reducing costs, but demand trusted relationships and community building. We proposed three things, which I hope you will like. One is that carers, as 1 in 10 of the population, 2 in 10 in the 50 to 70 population, could, with a small amount of support, be able to reduce hospital admissions and place of death, saving an enormous amount of hospital time. I don't want to say costs, because unless they transfer the budget from the hospital to primary care, of course, it won't change the cost at all. It will merely reduce the pressure on the hospitals. But reduced pressure on the hospital is something they're very interested in. So if generalists as GPs and other primary care practitioners, and generalists as carers, so that they both are unified in having to deal with whatever comes through the door and can't simply signpost people to somewhere else, and both of them need support to develop. The second is the work that Connie is doing on the Brazilian model of community health workers, that they could be something that people would see can be adopted fairly easily and help develop communities, not merely as an outreach arm from medicine to do blood pressures, but to help build communities. And the third is to a challenge to GPs as a body to take the notion of generalism and generalist primary care practice into the 21st century, applying lots of the theory and practice that we know is necessary in generalism, but isn't normally in the training, which is around the administration of medical science. Also talking about a development program, not just for primary care practitioners, but for all doctors, in order to help people to think collaboratively about local communities for health.
And yet, if we can, as it were, inveigle ourselves into these other areas, we might well get some, hopefully, success, rather than it being a standalone work that could be dismissed.
Three quick things. One is we've met very similar people to you. Would be very good to join forces, David and Paul. Secondly, you mentioned, Paul, that there is good evidence that this kind of community work can save money. I haven't found that data, so if you have good, strong evidence about that, I'd be very keen to see it. And thirdly, these community health workers, the Brazilian model, there's lots of talk in the papers that actually Streeting has taken this on as a real policy and is going to introduce it, which is fantastic. I've also talked to Matt Harris, and my concern is that these workers are primarily focused on the individual, with a rather sort of secondary community responsibility. And I've written to Matt saying, if it's true that Streeting has this policy, is there a way in which we could talk about ways of shifting the balance towards community, or balancing it out between individual and community? So
we've presented on the Brazilian community health workers along with Professor Facchini, who was one of the architects of the community health worker movement in Brazil in 30 years ago, and Streeting was quite interested in that, and then it kind of got portrayed in the papers as a kind of initiative to get people back into work, and I immediately thought it's going to be a similar thing to the social prescribing link workers, which kind of took the revolutionary idea from Bromley by Bow and kind of almost killed it with the approach that was taken, even though it did massively change policy. But I don't want that to happen to the community health workers, because I feel what you're saying, Brian, about, and they're not just, they could be transactional and task focused, or they could be real sort of human connections and building the community. And we actually have evidence that they do a lot of community work. So because they are from that community, work in that community, they have coffee mornings, they work with the community champions, and they actually really transform the community, and they work with the household, they bring the neighbors together. And I think as long as this is preserved and they actually are non-agendaed, as soon as you introduce a kind of task or agenda, then it becomes corrupt. It's like a sales pitch. So what we've done actually is we've written an editorial that we've submitted to the BMJ. I don't know if they're going to print it, but it's basically all the people around the country, including the NAPC, who've been involved in developing this model, to say it absolutely has to follow the principles of pivoting to a relational, place-based approach that honors the comprehensiveness, the relational aspect of it. And also I've reached out to Dan Hopewell from Bromley by Bow, Jill Oro from Growing Health Together, Julian Abel from Compassionate Communities Forum, because I feel that often these models get pitched against one another. So whenever I talk about the community health workers to policy people go, well, what about Communities Forum or Bromley by Bow? They've done this for years. And I kind of feel if we all get together and say we have a completely joined up vision about this, it's about a kind of culture shift towards the relational and human connection, then it's much easier. It's much harder to kind of subvert it into something that it's not supposed to be.
I wanted to respond to what both Paul and Brian were saying about the issue of cost. Earlier today, I sent to Lucy and to a few others amongst you some case studies which show that working in the sort of COI sort of way at community level can not only reduce hospital admissions, as Paul was saying, certainly can produce a social return on investment, and sometimes can even produce an economic return on investment. And I've also mentioned in there some evidence about how good value for money the arts are. And I noticed Liz is on this call. And I remember, Liz, I think you're saying you work using the arts. And I also often wondered whether your project has actually been evaluated in some way, because I think if it has, that would also be a great example of the use of the arts at a community and neighborhood level.
I know what Cornelia is saying is music to my ears, because I was going to ask, have you linked up with Julian Abel and the Compassionate Communities? Because I'm sort of linked to them, and my co-trustee and colleague Francis de Cunez works very closely with him. And Brian, there's evidence that Helen Kingston produced that they reduced costs substantially. And they reduced hospital admissions, I think, by 30%, which obviously was reflected in so that. And also, I think that the other thing is to mention green prescribing, and that again is being shown to be value for money. But I think it's so true, this idea that it's got to be relationship based and place based is absolutely key. And Julian certainly would say that, and that one of the key reasons, if you like, for another social determinant of ill health is loneliness and relationship poverty. So that's something that needs to be brought in. And finally, I saw in the paper something which or some email that horrified me. It said that they were the government's planning to give £20 per patient not sent in to casualty, but for GPs. And I'm thinking this is going to create perverse incentives. It's absolutely the wrong way to approach this. Are we back to extrinsic motivation and all the problems that go with it?
Before we move on, Kat, could I just point out that we actually, Bromley by Bow has been mentioned several times already, and we have both Sam Everington and Siobhan Hicks on this call at this moment, who are sort of the Bromley by Bow leaders, so all very, very senior in that arena. So there's a great link there as well. And the other thing I want to point out is reducing hospital admissions doesn't reduce costs. It reduces hospital admissions. it increases the cost in primary care and other people who do work in the community. But unless there's a mechanism to transfer the funds from the hospital sector to what's going on in primary care, the cost doesn't go down, it goes up.
From primary care development that we wrote for the journal is about we might need to have a budget rather than those narrow incentives so people can invest more in the community rather than from the monies they've taken out of hospital by taking some of the work. But this item price service payment, what Kato mentioned, is a truly dreadful idea. But a budget for community or neighbourhoods or something, even a partial budget, may be the thing that might help that.
We've put forward the idea that if you consider neighbourhoods to be case studies of health or healthcare or health something or other, that routinely gathers data around things like place of death and emergency hospital admissions, you might be able to demonstrate in real time the overall savings of effort in healthcare. Which isn't, and the argument would then be, therefore, you need to transfer more money into the primary and community care that is more cost efficient than hospital care, including things like, lots of follow-ups that aren't necessary, being able to use AI and communications, things like mobile phones to follow up, using carers and focusing on households rather than the same patient going back and forward. And I want to credit Craig Bishop for the next kind of bit. He's our Irish friend over there in my left-hand corner. He said, we must perhaps stop persuading people over here and persuade people over there, using video, media, the arts to show to the world, the healthcare world, that actually it's not just doctors who are important. Something along those lines. Excuse me if I've misrepresented you, Craig. So the video I want to show is merely what I thought might be a way to use the arts or to get to move forward the ideas of community-oriented integrated practice. Hello, everybody. Community-oriented integration network is a network of people, friends who want to develop healthy, compassionate communities at local level. Now, one of the difficulties about this is the language you have to use doesn't do justice to the richness of what's going on. And we want to rectify that by using short videos, 2, 3, maybe 4 minutes, that reveal something beautiful about the everydayness of life. So, for example, here I am in a garden. You can probably hear a bit of water cascading in the background, the birds, the aeroplanes, see the different colours that are around. Now, none of that will come across if we were just writing it in a book about the fact that we want 3-minute videos. Now, the idea for this came out of the Brazilian community health and well-being workers in Brazil and now in London and England. These are people originated in Brazil. Of course, Brazil is where Paulo Freire came from, the great educationalist who argued that you learn more by reflecting on experience than you do from textbooks, and you need a bit of both. The Brazilian community health and well-being workers come from the local areas, and each one would have a household of maybe 150 houses that they visit each month to be helpful in one way or another. And because they're relatively able to do whatever comes to mind, they very often react to the very real problems of every day, like the need for care and understanding health and conflicts and so on. The danger is that when they become more established, they become medicalized, which means that they get subject to medical, narrow focus kind of things, like doing blood pressures or blood pressure control. These, of course, are very important, but the higher potential of these workers is to be able to help people to build communities. And that's what we in COI want to be able to foster. So please submit or think about, put your thinking hats on about how to do this, and send in these small videos vertically, please, so that we can then find ways to cascade them onto mobile phones so that people can see them. They can become part of training programs, helping people in that area to realize that they're not alone and whatever. So please think about how you can maybe just talk to the camera like I'm doing now, or video people and edit it down to something that is small about the difficulties of how difficult it is, really, Well, you can work it out. You will know. In fact, if you're interested in this, you will already have a good idea. Give it a go.
A great shirt. Thank you.
Colour helps, yeah?
Don't like the glasses.
No.
You really touched on something. There's a drive from the community health workers as well, who really undervalue their own skill. They think like, oh, we're not medical. We can't do anything. We just sort out toenails, and you think, well, that's, that kind of visit and sorting out someone's toenails or getting them a chair is much more important. It makes such a difference. And I can see how they prevent hospital admissions and A&E visits by just doing those simple things. But we had Bernardo, who was a Brazilian community health worker. He came over to shadow our teams a few weeks ago, and we asked him, are you guys trained in disaster response? Are you doing anything about active bystander training? And he said, we don't really want to be trained to pull people out of rubble. Our expertise is showing the ambulance where to go and who's living in the houses and which pets are there. And I love that we really underestimate the soft technology of communication and caring, and that kind of that story needs to be told, that we get a value shift. We all value the sharp end, the saving lives and instruments, and it's that narrative that's really harmful, and then they get caught up in it as well.
Connie, we're not likely to get to the video made by Laura Donnelly from the Telegraph, but I was quite interested. I think the 3-minute video that she produced there is really excellent, excepting she's picked out all the medical bits. I mean, she's highlighted all the medical bits. The toenail clipping and the pat on the back is kind of there, but it's downplayed.
I agree. And actually, the case studies that come out, they're all, so in Cornwall, there was a beautiful case study of a woman who was caring for her husband and hadn't been outside for a long time, didn't have any friends, no contacts, and the community health worker said, what do you want to do? What would make you happy? And she said, I want to walk by the beach. I haven't been for years. And they walked, and she said, I want to go swimming, but didn't have a swimsuit. So the community health worker went and got her a swimsuit, and then they went swimming together. And this is the kind of dedication that you get when you build a relationship with someone, rather than here's a leaflet, join the swimming group. I mean, nobody joins any swimming groups, do they? On a leaflet. And it's that quality of human relationship and caring enough and getting to know somebody. It's kind of like the valuing the slow development of relationships. And we have so many case studies. I wonder whether we can bring the case studies to life. I was just thinking that when you were talking with the video, because there's such beautiful stories and they're all about the little human touch.
I agree with you very much. It's very hard to show that by reading a case study. It's much, I think, in theory, much easier on a lovely video.
I keep coming back to Ireland is such a small entity. Sometimes you can see things more clearly when something is small. And I think where it came from was this notion that I don't know about British politicians, but Irish politicians do nothing until they sense in the zeitgeist that the population wants something. So that was where that idea, if you really want to try and bring about change, rather than focusing all your attention on the politicians and the permanent government, it's probably more effective if you could bring the populace with you. For example, the anti-smoking was very successful in Ireland because there was a consensus. So it's building that consensus. So the idea of using video was the quickest, easiest way of doing that. And I really commend you what you're doing. I also liked Connie's idea. The telling of those stories is what's going to get the populace behind it. And no disrespect to your videoing abilities, but the quality I had was sort of closer to BBC than Northeast London, I'm afraid to say.
That must be enough from me. One thing we need to think of is how do we disseminate this kind of thinking? In a moment, we're going to hear from Liz And on the back of some of the fantastic stuff that comes out of the Open Eye Film and Video Gallery is the statement that every day 5 billion photographs are uploaded to social media. So how do we make these things look good and reveal the message we want, and also how do we get them to people's ears and eyes?
Sorry if you get to see my desktop. It's if any of you like neat desktops, you're really going to get upset. Sorry.
Cannot be worse than mine. We'll have it.
Quite chaotic. Sorry. Right, there we go. Okay. Okay. You all see that? Sorry,
Yes.
this is it's a bit meta because it is just me talking over them. So I did it more like a presentation. Sorry, I cheated. And it's over 3 minutes, but I'll let it play and then we can chat about it. Open Eye Gallery is a photography gallery based in Liverpool, and we believe passionately that photography and broader lens-based media can be a powerful tool for visual literacy and an educational tool to discuss health and well-being. And I'd like to use it today as a case study for COI. So photography, when working collaboratively with people, can be used to discuss difficult and sensitive subject matter and reveal stories which are often unheard. Our approach to working as an organisation very much echoes the ethos of COI's policies and work in the following ways. All of our projects are produced in collaboration with those communities directly affected by the subject matter, health or care context being produced. Photographers work together with participants and individuals to co-author the work. And we believe the best way to do this is to bring the expertise of individuals with their own lived experience, together with the expertise of the photographer to help visualise their story. We use cross-sector and co-commissioning approaches, which means we work with relevant sector partners across health, care and environmental sectors from the onset right through to the curation of the exhibition and sharing of outputs. And we believe in medium to long-term collaborations to allow time needed to build trust and develop ideas, but also understand the importance of shorter-term pilot projects to test viability and be responsive. An example of this way of working is an ongoing collaboration we have with photographer Ty Devlin and individuals living with and affected by dementia in Liverpool called the Serve Dementia Group. We worked with a Merseycare NHS Foundation Trust to co-commission the project with support from Arts Council England. Life Beyond Diagnosis was a project between 2016 to 2018, where a number of the group worked with the photographer to co-author a series of photo stories, which break the stigma associated with dementia and reflect their lives as individuals, not as a condition. It gave the participants with dementia the autonomy and agency to describe the often unseen or misunderstood experiences of the condition and helped visualize what is often incredibly difficult for them to put into words. Gina's image here reflects the difficulty she had with grasping words and letters, which day to day would disappear or reappear from her memory. Whilst Roy's image here focused on actual events of confusion he had in public spaces, where people didn't realise that Roy's actions were a symptom of the condition and his way of dealing with it. The project took a person-centred narrative approach rather than a medical way to explore dementia, and has had a hugely positive impact on the people involved, the public, and some medical staff who came to see the work, such as the quote we can see here from the doctor, who says, "As a medical doctor, my knowledge about dementia is scientific. Visiting the exhibition space gave me a new, more emotional perspective." Following on from evaluation and reflection with the group, we worked to secure funding for a legacy programme which broadened the work to collaborating not just with people living with the condition, but also those in the community and public sector who are affected by or responsible for the support of people living with dementia. The project looked at key aims, which again echo the approaches the COI papers are calling for, which is to use arts and visual literacy to promote health literacy for wider audiences to understand the condition, to advocate for social interactions and networks as key interventions in reducing health deterioration, and specifically encouraging more dementia support networks to be established across the UK, like the Liverpool one. It also aimed to create a better reciprocal understanding between the people who are living with the condition and the third and public sector services on how to support them. The second project was called Across from the Kitchen Table, Hewer's Community, and was formed off a series of video conversations over brews and biscuits, with paired discussions between patients, carers, and wider public sector staff like policemen, NHS staff, and those working in social care, each giving their own context and experiences around dementia. The work also included a series of distorted everyday scenes and objects which further visualised the reality of the condition day to day for people living with it. And importantly, a 3D photographic sculpture which visualised the social ecology model originally derived by Yuri Brockenheimer, considering the role of different relationships and strands of society networks in people's lives. The groups were keen to share how important it is for social networks and circles to remain strong when living with the condition, and how in some cases new connections could be made, meaning dementia isn't always just associated with loss, but also can help form new relationships if supported properly within the community context. Again, the feedback was overwhelmingly positive within our gallery, and more mass-produced elements of both projects were created in the format of a community newspaper and booklet to ensure the work could be presented back in health, community, and high street settings. So I just wanted to finish with some limitations and challenges to the projects despite their success. So both the publication and newspaper had mixed kind of welcome by health and community partners when we were trying to distribute them within the community and health settings. So for example, hospital wards for elderly patients embraced the newspaper as an educational tool for staff, while some GP and community centres refused to take them. There were queries around whether there was still a taboo of the subject matter itself, but also a hesitancy that an art project publication could hold useful information. And we also worried about our original aim around encouraging dementia support networks to be established across the UK, as in reality, even with the support of our NHS partner, this was very hard to track if we had been successful or not. Thank you.
I see silent claps all around. Thank you, Liz. Wow, that was really good. I actually thought that was sort of almost the middle, what we're talking about evidence and then the organic video showcasing. So I thought that was actually really effective. And you do win. That is one organic desktop you got there.
I'm sorry. I realize it gives people some people the fear. I've just learned to embrace it. Yeah, I guess I did want to end on that point around. So someone mentioned it earlier about this idea of impact and data and evidence, and I think that's probably one of our greatest failures within the arts. We do reporting and we bid for funding and we do evaluation, but often a lot of the way we evaluate tends to be narrative heavy, and I wonder whether that is useful in terms of the kind of stats and data that you're trying to get across to policymakers. And that idea of impacts, that's something I wanted to end on.
Liz, amazing. I just wondered, very interesting that the organizations weren't distributing, what appear to be brilliant publications and pamphlets and so on. And I just wondered why you think that is. Is that kind of typical large organizations worrying about liability? Does there need to be a little bit more work to help them understand where you've come from so that they feel more comfortable with that? Is there
I mean,
something like that there?
yeah, the responses we had, it never really necessarily felt like it was like, if I'm honest, it felt very hit and miss depending on the particular practice or individual center you went into. So it felt like just, I don't know, have a better way to describe it, the vibe of whoever ran that center.
Okay.
So, you know, we had people that approached us who had picked up a newspaper. So a lady that was running one of the elderly wards in the Northwest had got in contact with me and the photographer and meet her staff and talk through the newspaper with her staff, because she thought it was such a useful tool for them to sort of recognize some of the symptoms and kind of side effects of the condition. So we had people that would reach out to us on that extreme, and then people who just wouldn't even let us leave the newspapers in the waiting room of a GP. It was like a blanket sort of, no, we can't take things like that if it's not medical advice. We can't, you know, there was no, yeah, it really did seem to depend on like who you just ended up meeting that day when you're trying to distribute things. And when we worked with our NHS partner, Sarah Butchard, she you know, she did her very best. She still takes the pictures on tour to conferences, events, whenever she can. She uses them as tools. But she often reflects it's the nature of who you come into contact with about who will or not receive
whether it's worth getting some more help from the commissioners, you know, so that you can get some sort of seal of approval for some of that, which might make it easier for the organizations like the practices to have that material. They just may be worried about that kind of third party documents and, you know, what happens if something goes wrong. But there may be a way in which you can sort of, you know, provide some comfort to them, you know, by getting some sort of I don't know, approval somehow, you know, from you know, an organization like the commissioners that might, you know, then be supportive with it once they've looked at it. But it's just,
yeah, I mean, the NHS, I mean, they've got their logo slapped all over the publication. Like, it's not
okay. Yeah.
The partners that commissioned with us were fine. I think it was more about when we then in reality tried to distribute it, how welcome it felt, or useful it felt, maybe.
Yeah.
It was almost like we had to hide. I feel like maybe if we backtracked, we almost had to hide it as an art project, and maybe then they would have taken it. I don't.
Amazing, isn't it? Yeah. Crazy.
Liz, great presentation. In response to what you were saying, I think it's understandable that the arts have been narrative heavy. But if you look at that link in the document that I sent round, you'll see that actually the arts have now been evaluated, and there is quite a lot of good, solid economic evidence in support of them. Because I think you're right. I mean, I agree with what Craig was saying, that people are motivated by stories, but there are local players, ICBs, ICSs, local authorities and others, who are going to want something harder. And there is that evidence, fortunately, coming to the fore now, because I totally agree with what Brian said, something he put in the chat. You need the stories, but you need the evidence. You need to appeal both to the heart and to the head. That's the way you'll carry the maximum number of people along with you.
Liz, I wonder if the doctors need to be involved earlier upstream. You know, that picture of on the wall that went through rather fast. I've seen it live, and it's absolutely stunning. The way you perceive dementia as being lots of little holes of understanding that don't connect. And to help to understand what dementia feels like and looks like, it's absolutely brilliant. But I'm kind of not surprised it's a bit challenging to doctors who think that dementia is one thing, a label that you have. And I just wonder if they need to be part of the co-production of it, sort of like, well, I'm probably overly ambitious, but it's a brilliant way of understanding dementia.
That's a good next commission then. We'll collaborate with all the doctors to co-produce a new piece.
Connie put in the chat as well, if you could work with local academic partners, and I mean doctors, etc.
Tell me and Liz. I love it. Yeah, actually, I only mentioned that because I work at the Applied Research Collaborative at Imperial, and our dementia fellows are working with the community health workers around photo voice as well to get residents with dementia to sort of document what's important to them, and I think maybe partnering with your local arc, or they always have to show a real life impact, real world impact, and this could be one of those.
I thought it was brilliant. I think you mustn't see it as a failure at all. I'm very influenced by the work of Ian McGilchrist, and this is right and left brain stuff, and we're so much in the kind of left brain, rational, measurable, but it doesn't mean that this is not having an impact. It's just that it's more difficult to show, and that is to be expected. And I recently saw a film about dementia, which was beautifully done. And actually, the filmmaker had worked with all the staff in the care home and had offered them a course in filmmaking, so that they had a crash course, so that they were very much involved in how the film was made. But it was extremely powerful, and I think photography has a similar impact. So I just want to say that don't see it as a failure, just see it as it's like two languages, two ways of seeing the world that are different, and it doesn't mean that one is better than the other. But I'm also kind of disappointed in my fellow GPs, I have to say. But my daughter is working down in Plymouth, and she's working with GPs and the PCT and so on again, this kind of green prescribing. She says it's like 50-50. 50% of GPs, they see, they enthusiastically embrace it, and the others see it all as tree hugging, softy. Yeah. So there is that attitudinal difference with different people, but it's finding the ones that will champion you and support you, and then kind of spread it out, and it takes time. But when people see the impact and hear about it, then they'll be more ready to embrace it. Yeah.
Liz, I totally forgot what you're talking about when you talk about the metrics and how we measure impact. And I'm currently working on a program called Recite, which is all about a community-led creative health approach using the power of storytelling to tackle avoidable and unfair differences in health. And when we were developing this work, we were talking to commissioners about, well, why can't you start doing things differently, and why can't you start commissioning differently? And again, it's very much about where you've got to provide the evidence of your impact, and it's really difficult to get commissioners to move beyond those sort of hard numbers. And with the work we've done, and what we're trying to do with Recite actually is collect the stories and do lots of creative things, but then at the same time we're working with some University of Liverpool who are doing a lot of the number crunching, so we want to produce numbers to show impact as well as stories and other things, and sort of try and convince that way. And just a little bit about myself, for those who don't know me, I've been mainly, for a lot of my life, I've been working in sub-Saharan Africa, actually working at the interface between communities and primary healthcare, very much trying to tackle issues around health equity and quality of care, and probably had a lot more success influencing policy in sub-Saharan Africa than in